It's because, yeah,
Okay.
my bad. Yeah.
Okay. Will you announce our topic?
Yes.
Please.
You are going to talk about the lower level violences, which is not, it is depending of your point of view, that you do not have alternatives. As you, I mean, the patients, we do not have the alternatives to just go for the psychological treatments or anything else. This kind of, we are not talking about big human rights violations, but this is something ongoing and it happens to everybody. It's mass scale. This is the topic that you're gonna cover, if not mistaken.
Okay. We speak, Craig and I, we will speak about human rights violations via misinformation about the risk of dependence of psychotropic drugs and the denial of support and withdrawal. Myself, I'm a certified pedagogue, a social scientist, and an independent publisher in Berlin, Germany. Until 2010, I was a long-standing board member of the European Network of Ex-Users and Survivors of Psychiatry. This means I belong to the group of people with lived experience. I deal with the topic of withdrawal from psychedelic drugs since more than 50 years. Give lectures and training also for psychiatrists in clinics. And I published books about this topic, for example, Coming Off, Psychedelic Drugs, also in German, French, Greek, and Spanish. It was the first book in the world about successful withdrawal from neuroleptics, antidepressants, and other drugs. And together with my friend Craig, you see him, recently I edited the book, Withdrawal from Prescribed Psychotropic Drugs. Hopefully, Enric can enable translations into French and Spanish. Last Friday, in Enric's lecture series, Political Abuse of Psychiatry, the former Human Rights Council Special Rapporteur Dainius Duras spoke in his impressive presentation about political abuse of psychiatry, amongst other places in the former Soviet Union. After his lecture, I have asked him whether he could see the border between the misuse of psychiatry and its correct therapeutic use. Admittedly, a difficult question that probably cannot be answered straight away. Afterwards, I set about asking the same question myself. On Wikipedia, I found a page, Political Abuse of Psychiatry, and there the definition of Robert van Boren. Robert is the Chief Executive of the Human Rights and Mental Health Federation Global Initiative on Psychiatry. I cite him. Political abuse of psychiatry, also commonly referred as a punitive psychiatry, is the misuse of psychiatry, including diagnosis, detention, and treatment for purposes of obstructing the human rights of individuals and or groups in a society. End of citation. Craig and I are talking today about informal psychiatric human rights violations. For this reason, I would like to broaden differentiate the understanding of political abuse of psychiatry in this form. Macro and micro political abuse of psychiatry is the use of psychiatric diagnosis, of detention, of coercion, of administration of psychotropic drugs and electroshocks without informed consent, or with misinformation about treatment risks, inclusively risks of dependence on psychotropic drugs, and withholding of support in their withdrawal for the purposes of obstructing the fundamental human and civil rights of certain groups and individuals in the society. This would be my definition. I don't want to talk about macro political abuse. Others have already talked a lot about it. Formal coercion is well known. Informal coercion is less visible, has so far been little addressed is no less profound in its effects and is a pervasive psychiatric practice worldwide. Informal coercion is characterized, between others, I repeat, by withholding information about the risks of prescribed psychotropic drugs, by concealing the risk, particularly on antidepressants and neuroleptics, and by withholding of support in their withdrawal. These substances have a number of toxic, occasional, life-threatening, or even fatal adverse effects, whether they are administered compulsorily or with the approval of the affected person. People with serious psychiatric diagnosis and appropriate treatment, that is, administration of neuroleptics and antidepressants, have a reduced life expectancy of 20 to 25 years on average. And these substances cause physical dependency. Now I have to mention some psychiatrists. Rudolf Deckwitz is a former director of 2 psychiatric university hospitals in Germany and also a former president of the German Society for Psychiatry and Neurology. He was the first psychiatrist in Germany to provide specific information about the risk of drug dependence on neuroleptics and antidepressants. In 1967, he wrote about psycholeptics, which include antidepressants and neuroleptics. I cite, the reduction or discontinuation of psycholeptics lead to considerable withdrawal symptoms, which are in no way different from the withdrawal symptoms following the discontinuation of alkaloids and sleeping pills. End of citation. The chemical group of alkaloids includes, for example, morphine, well known for its potential to build dependency. Its withdrawal can also bring major problems, including life-threatening circulatory disorders with shock states. And already in 1965, Deckwitz had written about neuroleptics. I cite, we know now that it is extremely difficult, if not impossible, for many of the chronic patients to stop neuroleptics because of the unbearable withdrawal symptoms. End of citation. Gerhard Gründer is another German psychiatrist. He's a former chairman of the Task Force Psychopharmacology of the German Society for Psychiatry and Neurology. He warned of a vicious circle that can arise from continued neuroleptic drug use. Not publicly, but in his technical book addressed to his colleagues, he wrote in 2022, I cite, the development of supersensitive dopaminergic systems illustrates the dilemma of antipsychotic pharmacotherapy. Every treatment with dopamine 2 receptor antagonists, these are substances directly against the action of dopamine 2, potentially carries the risk that supersensitivity of the target receptors will develop. However, once this has occurred, a vicious circle of tolerance development, dose increase, and further progression of the pathophysiological process often follows. End of citation. Similarly, in the same year, the Italian psychiatrist Giovanni Fava warned in his book, Discontinuing Antidepressant Medications, of the consequences of adaptive responses of continued administration of antidepressants, which involve changes of special subtypes of serotonin receptors. I cite, the clinical events that may follow tapering and or discontinuation of antidepressant medication are very variable. They may range from no or limited withdrawal symptoms to severe withdrawal syndromes. They may occur within days, if not hours, or have a delayed onset. They may fade away or persist for months or years, accompanied by new disorders and or greater intensity of the original disturbance. Further, Withdrawal and persistent post-withdrawal disorders may be associated with other manifestations of behavioral toxicity, such as a loss of clinical efficacy, paradoxical effects, switching to bipolar cause, resistance, and refractoriness. Drug firms and doctors withheld a warning of those affected and their relatives from tolerance formation of psychotic drops, especially of antidepressants and neuroleptics. Most of the psychiatrists deny the risk of drug dependence on antidepressants and neuroleptics with these arguments. Withdrawal, or how they call them discontinuation symptoms, are only a symptom change of the diagnosed disorder, are greatly overstated and solely signs of medical mismanagement and due to too rapid discontinuation, are usually mild, self-limiting, and only in extremely rare cases classified as more severe, are merely reported among the layperson withdrawal community, and the resulting publications are filled with anecdotal reports of bad outcomes. Are neuroadaptive processes, as they also occur when discontinuing drugs prescribed in physical medicine. And persistent withdrawal problems are only incidental ones. If an antidepressant discontinuation syndrome occurs, for example, the DSM-5 guidebook names one easy possibility of solving the problem: taking antidepressants again. This way of dealing with withdrawal symptoms is not new. People dependent on alcohol also alleviate withdrawal symptoms by continuing to reach for the bottle. Finally, and this is the killing argument, there is no craving for antidepressants or neuroleptics, but craving for a substance would be indispensable condition for the existence of drug dependency. Okay, so far the community of psychiatrists who deny the existence of drug dependence on neuroleptics and antidepressants. Craving as a crucial characteristic of dependence was incorporated into the definition of drug dependence in the psychiatric classification systems in the interests of the pharmaceutical industry. Court judgments in the 1980s had led to convictions of psychiatrists who had not warned of the risk of benzodiazepine dependence. The judicially enforced information about the risk of such a drug dependence had led to a significant decline in the sale figures for these substances. To think that people feel a craving for neuroleptics, that means for substances that are administered in totalitarian states to punish and torture dissidents, requires a dark imagination. And it's so absurd. Nobody has ever claimed that there's a craving for neuroleptics and antidepressants. You could just as easily claim that a drug dependence only exists if the person concerned over time grows an elephant's trunk out of their face. And perhaps many would also fall for such a definition if it were only spread by people in white coats or with medical doctor titles. There are groups in Germany and outside, for example, the International Institute for Withdrawal of Psychiatric Drugs, who publicly criticize these primitive tactics. We are not alone. In its report to the General Assembly of the United Nations in 2015, the Human Rights Council Working Group on Arbitrary Detention demanded not only the immediate cessation of any forced treatment, but also non-psychopharmacological assistance. And in its guideline number 20E, the final demand was, I cite, assistance in withdrawing from medications should be made available for those who so decide. End of citation. In the same year, this demand was included in the same wording in Guideline 14, the right to liberty and security of persons with disabilities of the UN Convention on the Rights of Persons with Disabilities. And in October 23, last month, 2023, the World Health Organization and the United Nations High Commissioner for Human Rights demanded in the protocol mental health, human rights, and legislation not only a higher standard for free and informed consent, but also a governmental initiative to guarantee by law support in withdrawal. I cite, legislation can require medical staff to inform service users about their right to discontinue treatment and to receive support in this. Support should be provided to help people safely withdraw from treatment with drugs. End of citation. We should be aware of these important statements and call on governments and administrations and organizations in the psychosocial field at all levels to implement these all too justified and overdue demands without delay. Experience has shown that the lobbyists of the pharmaceutical companies and the organizations of mainstream psychiatrists will do everything in their power to undermine effective measures against the micro-political abuse of psychiatry. Until this happens, the programs of support and withdrawal, it's our task to do everything in our power to publicize the risks and harms of prescribed psychotropic drugs and to develop a system of competent support for the self-determined withdrawal with further training, with publications, digital as well as analog, by participating in self-advocacy organizations and organizations of humanistic anti-psychiatry, or in organizations that seriously want to reform psychiatry in the direction of human rights-based assistance. Of course, it would be even better to develop a system of psychosocial support in which psychotropic drugs only play a subordinate role. I mentioned some statements. You can find some of them and their sources on the internet. The address is peter-lehmann, LEHMANN.de, D like Denmark, E like England, /ABC. And you can find all of them in my chapter for and against dependence on antidepressants and epileptics who benefits in the book Withdrawal from Prescribed Psychotropic Drugs. This book, which I mentioned already, is about practical withdrawal concepts for professionals, patients, and relatives. Craig Newnes will now continue together with him. I've published the mentioned book. Thank you very much for attention. Craig, now it's your turn.
Can you hear me now?
Yes.
Okay. Well, thank you, Peter. Wonderful as ever. I shall say a little bit about me, not very much. The first thing to say is you can find, if you just Google my name, Craig Newnes, you will discover all the books I've published, all the activities I've done, etc., etc. I don't just publish psychology and critical psychology books. I've written novels, I've written children's books, and all of those are on, you'll find them on Google. I've been editor of the Journal of Critical Psychology, Counseling and Psychotherapy for 35 years. So I'm getting quite old and tired. And I guess the main kind of brief of the journal is to critique all the claims that psychotherapy, psychology, and psychiatry make. And that's very easy to do because so many of the claims are simply claims. They're not based on real entities. So, for example, the id, the ego, and the superego, they don't exist. They're just names. Schizophrenia doesn't exist. Behavior exists. Conduct exists. But schizophrenia, there is absolutely no construct validity or reliability for that particular construct. It's just a word. And JCPCP says that kind of thing a lot. I'm going to critique a little bit our own book because I spend my life critiquing things. So this is the book that Peter mentioned, Withdrawal from Prescribed Psychotropic Drugs. I would recommend it. It means that I can eat dinner because I shall make a great deal of money. I don't think I will. However, what I'm going to talk about are there are many, many suggestions in this book for how to safely withdraw from psychotropic drugs. I'm going to talk about several things that make that very difficult. So, for example, the networks that this book suggests, networks that include compassionate psychiatrists, good general practitioners, kind relatives, friends, many of these networks simply don't exist. If they existed, people wouldn't get into trouble in the first place. So that's one problem. A lot of networks aren't available. Another problem is that deprescribers, people who systematically reduce the dose of the drug, they're also very unusual. What tends to happen, as Peter mentioned, is that if someone is experiencing withdrawal effects, what will happen is they will increase the dose, not decrease the dose. There's also a simple problem of the sheer volume of work for the staff involved. So junior doctors, care staff, they have an enormous amount to do and not very much time to do it. Because of that, it becomes much easier to simply give somebody a tranquilizing drug. And although we call them antipsychotics, they're not antipsychotics, they're just tranquilizers. It is just easier to give someone a tranquilizing drug, because if that person is doing something very difficult in a care home, then, and there aren't many staff, then for the staff, it is easier to give the drug. If it is a junior doctor who goes out into the middle of nowhere, goes out into the, I live in a very countryside, a rural place. And if there were a junior doctor who had to be called out at 3 o'clock in the morning in order to see someone who was experiencing difficulties, the chances are that what that doctor would do would be prescribe a drug, because that's the simplest thing to do. And I completely understand that. I'm not saying that's a bad thing or it's a bad doctor. I'm just saying that that's what people will do. There's also a problem of the sheer amount of non-information, well, lies really, that junior doctors and psychiatrists are exposed to. And you know what? So an example of one of those lies is that there is such a thing as paranoid schizophrenia. Well, there isn't. There is no such thing as. People have fears. If you call it schizophrenia, you've just invented a word. So that's one lie. But the other lies come from articles that are sponsored very frequently by drug companies. And I'll give you an example of one that came up online. It's a relative to Abilify, so it's an SRI, and it is now being prescribed for, let me just see this, for agitation in demented people. Now, being demented is difficult for many people, for relatives, etc. The thing that makes it more difficult is agitation. So this drug has now been approved for agitation in elderly people, for people who are dementing. However, it's in the JAMA neurology. But I looked it up. There were adverse effects reported by 40% of the people receiving this drug. Now that seems to me quite a lot of people. 40%. Another thing that I think makes it very, very difficult for people not to prescribe drugs. So they're surrounded by information about drugs, and they're given money by drug companies to go to conferences and all of that. But another thing that I think makes it very difficult is what's described as the gift relationship. What that means is someone comes to see a doctor, someone comes to see a psychiatrist, whatever, clinical psychologist. They come to see a clinical psychologist, psychiatrist, or doctor, and they give something. What they give is a history about themselves. They give some of their sadness. They unburden themselves. So they are giving. The problem for the therapist or for the doctor is that they immediately feel they have to give back. And frequently, if you're a therapist, what you will do is you will give back by offering another session. If you're someone who prescribes, you will give back by offering a drug. Now, the person may not take the drug, but that's what you've done. You've suggested that a drug is the answer. These drugs, as Peter was saying, because people aren't given realistic information about withdrawal effects, about the adverse effects of the drug, these drugs, the actions go against the Human Rights Act. Particularly in this country, the actions go against the Children's Act. Now, there are 2 clinical psychology courses in this country, University of East London and Liverpool, that are actually based on human rights. Now, I said I was going to talk about the difficulties. One of the difficulties for the clinical psychologists in terms of the human rights that they are meant to defend is that they'll have learnt about human rights, they'll have learnt the Children's Act as soon as they arrive in a busy outpatient clinic. They're expected to see as many patients as possible. And those patients might be children with parents. Those parents might be insisting that the child has drugs or has therapy. And what that means is there is no possibility, despite the Children's Act, of offering informed consent. The child is too young to accept in reality, if you're a therapist, you can't give informed consent because you have no idea what's going to happen between you and a patient. I don't know what I'm going to say in the next 20 seconds. You don't know how you're going to react. So how could I give you informed consent about what I'm going to say? One of the ways of attempting to give informed consent and to give people a chance of, at the very least, denying drugs or saying no to drugs is the living will. And Peter was a major part of creating the living will. Respect. Again, there is a problem with the living will. The problem with the living will is that in the kind of circumstances where people are incarcerated, they're put on what in England it's called being put on section. So they're sent into psychiatric hospitals, or they're given major tranquilizers, or they're even given electroshock. In those circumstances, there is no time for the person to find an advocate. There is no will on behalf of the people who are offering the treatment to discover if there is a living will. There must be many people who have been through the psychiatric system who have living wills, and no one knew that. I'll give you an example of how difficult this can become. I have a friend who is a high court judge. So he's up here. There aren't many high court judges in England, but he is. His son went mad. Well, all his son did was went down the street shouting, and people didn't like that very much. So the police were called. His father was called, as was a psychiatrist. The father arrived at the police station and said, "What are you going to do?" And the psychiatrist said, "I'm going to have to give him Dipixol." And my friend said, "I don't know what Dipixol is. What does that do?" "Oh, don't worry about it," says the psychiatrist. "He needs it. And I also think he needs to be put on section and sent to hospital for 48 hours. Now, my friend, the High Court judge, couldn't do anything about that. Despite the Human Rights Act, and despite the fact the psychiatrist had no legal training, he could override what the High Court judge preferred. There's another example, which is again Dipixol. A good friend of mine is a clinical psychologist. Her daughter went a bit crazy, started saying she was hearing things, was very, very upset and tearful, went into a shop and started shouting. The way to get yourself admitted to a psychiatric hospital is go to a shop and shout. It simply stops capitalism. It's a brilliant thing to do. If you want to get yourself arrested and sent to hospital, stop capitalism by going to a shop and shouting. This is what this girl did. The girl was sent to, well, she was picked up by the police, then she was sent to a psychiatric hospital. Her mother, who's a clinical psychologist, a senior clinical psychologist, arrived, asked what was going to happen, and the answer was, "We're going to keep her in hospital for 48 hours and put her on Dipixol." So that's two people put on Dipixol within 48 hours of each other that I know. And the mother couldn't do anything about it because the psychiatrist overrode anything that she said. There are many other examples I can give you. But these examples are, some are hopeful, some are less hopeful. These are about withdrawal. So I have a friend, Zach. I play in a band, and he's a brilliant guitarist. And he was on Prozac for 27 years. And I agreed to help him withdraw from Prozac. Now, one of the things I believe is it's not much easier, but it is easier to withdraw if you're taken out of the context that you live in. And I have a place in France. So I took Zach to France, and unbelievably, Zach went cold turkey after 27 years. And I literally had to hold him down for 4 days. Now, he could have died. He could have died. Thank God he didn't die. Zach hasn't had any of this drug for 7 years now. Equally, there's one of my friends, a friend of one of my friend's mum. She had hip surgery. And she had been on an antidepressant for about 15 years. She went into hospital for hip surgery, and they immediately took her off the antidepressant. And of course, she had the most terrible terrible withdrawal effects. So Zach was very lucky. He had me to do this. My friend's mum's friend was much less lucky, and she's okay now, but it's been 6 weeks, and she's slowly but surely getting better. And I'll give you another example of how difficult it is to prevent people being prescribed drugs, and this again applies to dementia. This applies to my mum, and I looked after my mum for a long time because she was very ill and very frail, but she began to lose her mind, and she was indeed eventually admitted to a home. Now, because she was admitted to the home, I had to sign a form that said it would be reasonable for them to prescribe drugs for my mother if she became agitated. And my mother spent 3 years in this home. She's died now, but she spent 3 years in this home being suppressed by these drugs. And I can understand why they did it, because looking after someone who's screaming at you and lashing out is very difficult. But even though I'm a psychologist, my brothers lived locally, all of that, we couldn't do anything about it because they insisted we signed a form that gave them the right to give drugs if they thought it was necessary. So just to summarize, there are some considerable problems with fulfilling all the things this wonderful book suggests. There are problems like people just don't have supportive networks. There are problems like psychiatrists who will deprescribe are quite rare. There's the problem of the sheer volume of work for junior doctors and for care staff. There's the problem of the gift relationship, where someone goes to see a doctor, they offer something of themselves, and the doctor feels they must give something back, and the only thing they can give is a drug. There's the problem that even though some clinical psychologists are well versed in human rights and the Children's Act, they go and work in places where informed consent, particularly for children, is impossible. And finally, there's the problem that even if you have something like a living will, people would have to know you have the living will. Even if you have the living will, in this country, it can be overridden by a psychiatrist's opinion. So I don't want to finish on a negative note, but sadly, that's where I need to finish. Thank you.
Thank you, Peter Craig. Thank you so much. Anybody would like to make a question? Then I do.
Can I say?
Yes, sorry, go ahead, please.
Warte mal.
Yes, we hear you.
Moment. I have a problem with my tablet. Can you hear me?
Yes.
Yes.
That was very interesting what Peter said, and also Craig Newnes was very, very interesting for me. Even though I already know a lot about the using of this kind of drugs. Maybe I'm allowed to tell my story trying to say it in a very quick way, my problems that I currently have since almost 2 years. And I was taking Cipralex, or in England they call it Lexapro, escitalopram, for 18 years. from 2004 to 2022. I had depression. I was in a bad mood. I had problems that do psychological problems in the 90s, beginning 2000. So I started to use different kind of drugs first, also Prozac, some others, sertraline, or called Zoloft at this time, but not for a very long time. They didn't help me at all. They made me exaggerated, they made me headache, they made me overdrilled, and I don't know, a lot of side effects. And then in 2004, I was suggested to take first citalopram. That doesn't help me really. And then they changed it, or my doctor changed it to Lexapro, yeah, for a small dose of 10 milligram. And as well as I remember, it helped me for a while. I have to admit, it helped me for a while. I would say maybe 6 months or so. But after a while, I came to my doctor and said, I don't feel well anymore. I have these side effects. I have nausea. I have weight gain and so on. But I was not aware about that this was really side effect of Lexapro. I was not aware of it. And all what the doctor did, he said, well, we have to increase the dose. No? And he increased to 20 milligram. And that was not good at all for me at this time, as I remember. And then he reduced it again to 10 milligram, then to 15, and in the end again to 20. And then I have to say I was sterilized. Yeah, I can say I was sterilized for years in a way that I was like being emotionally numb. You know, it's like I could do my work. I was functional. I would take care of my elderly parents. I could do my job, but I never can say that I really had and was enjoying my life. Yeah, I was living in my own world. I can describe it like this. You know? And all the years go by, and the side effects were getting stronger over the years. Yeah, stronger and stronger, especially I would say the last 3 or 4 years. And I had increased 15 kilogram, as a weight gain was a lot. And I heard the flash. No, it was like electric senses in my brain all the time. I had strong tinnitus. Sometimes I already didn't hear something anymore. It was a sound, a big loud humming sound in my ear, and in this ear also. But I was not aware where it comes from. Yeah. And my doctor always said, you have to use Lexapro, you have to take this drug, you need it. You cannot get rid of it, you need it. Yeah. And every morning I was taking my pill, then I had my coffee, it was going to work. I didn't think about it anymore. And then the side effects were getting so strong in 2020 already, and even more in 2021. Yeah. After my mom died in this Corona times in 2020, it was the horrible times I was going through, you know. First my father died, and then my mom. It was terrible. And I couldn't visit her anymore. She was in an elderly home only for a short time after being hospitalized for several weeks. And then the people were not allowed to get in anymore, and it was really terrible for me. And well, in 2021, in the end of this year, I got severe influenza, and the side effects were getting very, very strong. And I said to my family doctor, I want to get rid of Lexapro. I want to stop it. Yeah. I have decided to stop it. And then I called my psychiatrist. I could not visit him because first I didn't get an appointment very quick, and because I was with this influenza, he said, no, you cannot visit me. It's too dangerous for COVID and everything. This is too dangerous. We only can do online meetings or by phone call. And then he said, if you really want to stop this drug, reduce it every week 5 milligrams less, from 20 milligram, 5 milligram. So within 5 weeks in January 2022, I was finished with Lexapro, escitalopram. And that was too rapidly. Yeah, that's what I know now. It was much too rapidly. In February, March 1st, it was, well, I had this COVID. Then I had COVID also after my withdrawal, I have to say. I had COVID and I was laying in bed with like a strong influenza. But the withdrawal effects, they came very, very strong, protracted, I would say, in the end of March and April. Yeah. The heartbreak down over me. Yeah. I had nausea for months. I couldn't eat anymore. I had muscle pain. I had this brain fat. I had this humming sound in my ear getting stronger. I couldn't hear something anymore. Inside of me, a feeling it's hard to describe. I still have this feeling. It's terrible. Yeah. I'm restless. Sometimes I cannot sit down for hours. I have to walk always. I walk around all the time. And I cannot make any decision, even for simple things. It's sometimes it sounds ridiculous, but I cannot even make up my mind. Shall I make coffee or shall I make tea? That takes a long, long time. I cannot leave the house. I cannot work. Yeah. I cannot sleep. I have severe insomnia. But the insomnia I got when I made my reinstatement. That is the next point. For me, it's important to tell you all. I was suffering after this withdrawal in 2022 all the year through. And I thought about reinstating the drug, and there was a short period of time I reinstated with Brintellix. This is a medicine not available in Germany anymore. It was from Switzerland. It was ordered from Switzerland, and I read in the internet that it could maybe help with the withdrawal symptoms. And I tried this in June for about 2 weeks, but it made everything worse. Yeah. Again, after Brintellix, I got strong flu-like symptoms. Then I was sweating, I was freezing, I made a horrible time, hard to describe, really.
Rainer, I'm very sorry. I mean, it's a terrible story.
Yeah.
But I must interrupt you because Uta has raised her hand several times, and she would like to speak.
Okay.
Yeah, Rainer, I also wrote a little note in the chat because I told you to understand that these are really terrifying experiences. So we should make a workshop or something for everybody to have more time for exchange. And today we have to be shorter. So I am really, of course, I've been following Peter's work for many years. And initially, I remember I was against the idea that psychiatrists, as in brackets, medical professionals, should be legally prosecuted, or whatever the right term is, for prescribing psychiatric drugs, because I thought that the guidelines would tell the doctors, that patients need them. So the difficult legal situation. However, after after working with more briefly and a lot of exchange, reading different books, I just reread Anatomy of an Epidemic like 10 years after the first time, and it's horrifying. My interest awoke anew about the legal situation, and I'm not. So I do not know anybody who is an expert or a group of experts that would like to really investigate, yes, from a legal and human rights, professional legal and human rights point of view, if it is permissible to have guidelines still make the claims they do. And anyway, what I'm interested in, is there any people from the legal studies field that are interested to look deep into the subject matter and to come up perhaps with legal advice that is more useful to us?
Yes.
Oops, sorry.
The simple answer is yes. So in the book, there is a chapter by Jim Gottstein, and Jim Gottstein is a lawyer in Hawaii and Alaska. There's a very good chapter by Jim. And there's also a chapter by Marina Langfeld, and this is about the liability that drug companies have because they don't give enough information about withdrawal and other effects. And it is possible to, and it has been done, it is possible to take drug companies to court because they don't give this information. And there's also, there's also Peter's chapter on the Psychosocial Advance Directive, the living will. But in terms of pure legal advice, the two chapters are chapters 25 and 26 by Marina Langfeld and Jim Gottstein. So it's there, it's in there. Hey.
I can I speak? Can I say something? I had the question to Peter Groth 2 hours before, how because I discuss this problem very often with Marina Langfeld. Marina Langfeld is what is the English term? Oberstaatsanwältin. Do you know the English term, Ute?
No, I will try to Google something.
Okay. Yeah.
Complicated.
And she was a German representative to the United Nations in this committee against torture and mistreatment. And she said it's very hard to go to court against big drug companies because it's expensive. You should have a private securance who takes a risk. Then there is a problem to find if a court calls, they decide for an expert. In general, it's mainstream psychiatrists who will see there is no dependence, no problem. I guess in such a case like Rainer tells, it's so clear there would be the chance, but he has no insecurance, so there is no chance because he cannot pay this very, very big costs. It's a big problem. It's the main problem. The chance would be there because I guess in all European countries there is this law on medical drugs where the manufacturers have to guarantee that they inform the doctors according to the science about risks and all these things, and they don't do it. If you look on these summaries of product characteristics, also called information inserts, Drug companies tell doctors to withdraw, for example, clozapine slowly in 2 weeks, which is absolutely a crime, because clozapine is totally known for its problem to come off. And if people have taken clozapine for 20 years, it's 100% sure they get psychotic if they withdraw so quickly. And even doctors with goodwill who want to support and follow these instructions for the manufacturers and withdraw such drugs within 2 weeks, it's a catastrophe. And it's similar also with a lot of SRIs. They say for the 13 and others, they say do it slowly, take 2 weeks, which is totally nonsense and which is really a crime. And if you speak with any psychiatrist, they say, oh, what a nonsense. But this is the practice. And to go against this practice, you have to go to court and fight against the drug companies. The situation has been a little bit better because you do not have to prove that exclusively a damage is caused by a drug. Meanwhile, there was a court decision by the European Court which say when it's very likely that the damage is caused by a drug, this is enough. But yeah, to find somebody who is in a good position, this is a real problem in Europe. And I hope our book will encourage doctors.
Yeah, thank you. Just really keep us informed if there's more people who are willing to take up, like scholars, scholars from legal scholars. If there's anybody who really wants to take up a fight, I think that would be fantastic. I would much welcome the news. Good news.
Yeah, but it's not only the money, it's also the nerves, which have to be very strong. Yes, a problem.
I do apologize because I do not know how to name. Somebody was raising the hand. Is the last one in the list after you. If they still want to, that would be lovely. Last question.
You mean me? Hello.
That is it. Thank you so much.
So George, it's in Greek. It's George.
Fantastic.
So, hello. My name is George. I'm from Greece. In my profession, I'm a psychologist, and I'm a member of the Observatory for the Human Rights and Mental Health here in Greece. It's an organization. So I want to open the conversation that besides what is happening with all the companies which are dealing with drugs, there is another issue, which is the social narrative. What is mental health? Which is right now it's very big, and for me, thinking that's only the company that's actually suing, because that's not the case. A lot of people who are Christians that have some power, they don't know what is the psychiatry, they don't know what is the mental health, mental pain, and they contribute in a way which is very difficult. I'm in a case where a woman, she was in a situation with her, not husband, her boyfriend. He was violent to her, and she, in order to get away, she made a court order for her to get in psychiatry, and she gave her 2 months newborn baby to the police because she wanted to get away. After a couple of days, she relaxed and she wanted to get out and she wanted to get her baby back. Now, the prosecutor to give her baby because she has as a history, a mental health history. So they are now involved. The law prosecutors, they're now involved mental health professionals, and they all don't want to give the baby back because she has a mental health history. And the only thing that they are checking out is if she is getting the drugs or not. So this is the social narrative that is happening here, which is very strong, and it's very difficult to take it over.
Yes.
Thank you.
Yes.
Peter, Craig, do you want to comment on George?
My only comment would be that what we call mental health or mental disorder is expanding all the time, all the time. I could diagnose any of you, no problem at all. And there's a reason for that. The American Psychiatric Association votes all these categories into the Diagnostic and Statistical Manual. And what they want to do is expand it to such a point that anybody can be diagnosed. And now what happens, certainly in English newspapers, every day someone says, oh, I did this because I was depressed. Oh, I did this because I had this disorder, that disorder. There's a newspaper called The Guardian, and 5 of the journalists regularly talk about the fact that they are depressed. So it somehow or other, being not depressed, I'm not depressed. I must be absolutely unique. I'm probably the only person I know that isn't mad or diagnosable. But that's the problem. The problem is that the categories have just become so wide, and you can now have an excuse for any kind of behavior by saying, I did it because I was depressed. I beat up my wife because I was abused as a child, etc., etc. So I think to add to sort of George's point, I think part of the difficulty is just the expansion of the idea of mental disorder. And finding mental health is very difficult. I'm mentally healthy. Peter's mentally healthy. That's 2 of us.
I have read in a psychiatrist's book, the main problem is they are new drugs, but they need find disorders, new disorders to sell these drugs and to administer them. Rainer said he has an urgent question. Rainer, can you say it quickly and short? Short? Your question? Short, please.
Okay, I try. Peter, thank you. Like I said, I made this first reinstatement with Brentalex, and I tried again because I was suffering so much this spring in 2023 with a very small dose of escitalopram. And this made everything worse again for me. And I got a lot of additional symptoms that are very, very terrible for me to bear. Yeah? So I don't know what to do anymore. I see no way to get out of this nightmare. I go from doctor to doctor. I go to online. I correspond with online forum, but nobody can give me the right advice what I can do in my situation. I'm really absolutely despair, and I don't know what to do. Yeah, I really
Is
don't know. Is there a
this is the
way
question.
to?
This is
Yeah,
the question. What you should do.
is there a way that anybody might know? Maybe Drake. Uh, he's a very brilliant man who give me an advice what can be done, because my brain fog is getting worse. My cognitive disorders. I was speaking English very good, but I realized that I forgot a lot of words. Yeah, it's
Okay.
a horrible situation for me.
I just got a question from an American who wants to withdraw antidepressants and faces big problems, and he asked me, where should he go? Money doesn't play any role. And I recently read the book of Giovanni Fava, who is a psychiatrist in Bologna and in Buffalo, New York State. And I advised him, I guess this is the most competent person to go to him, to go to Giovanni Fava. This was my answer for him. And he was very lucky and said he will try to do it.
So I should try to contact him if he can give me any advice to.
I can give you Giovanni's email and you can ask him.
That would be great. That would be wonderful. Because
Okay.
I don't know how to survive. I can't work anymore. I have no money anymore. What can I do? No,
You will have it in 10 minutes.
I can't
he said.
sleep. I have severe insomnia
Okay.
since May.
But tell these things, Giovanni. You told us already.
Uh,
Okay.
I will. Okay. Thank you.
You're welcome.
Rainer, wishing that you find a solution, somebody, a community group that can help you. Not only one professional, sometimes what happens, only one available in the area or none. And they are also suffering because it's hard for everybody that wants to do something different. Like simple as not having to take the drug they have told you. Rodrigo, ¿quieres lanzarte y presentar?
Continues?
I'm
Hola.
asking Rodrigo. Hola. My apologies.
Ajá.
Let's go and yeah, en media horita.
Sí, yo voy a hablar en español chileno.
And
Siento
I'm
mucho.
gonna I'm gonna
Ajá.
transcribe in the chat if that's okay for everybody.
Primero un saludo para todos. Para Enrique primero por atreverse a organizar un encuentro como este. Un saludo para Peter Lehman, que no tenemos el gusto de conocernos personalmente, pero en contacto por su libro. Un abrazo especial para Rainer por compartir su experiencia. Gracias. Thank you so much, Rainer, for share your experience. Y es muy difícil para mí introducirme en esta charla porque tengo que estar pensando si lo que estoy escuchando lo estoy entendiendo bien. Y luego tengo que pensar cómo voy a decir para que ustedes me entiendan. Esa es una dificultad que me presenta el idioma, lamentablemente, pero le ofrecí a Enrique la posibilidad de grabar una pequeña charla para compartirla con ustedes con la posibilidad del subtitulado, para que al menos pudieran saber qué es lo que estoy compartiendo. Yo vivo en Chile, soy una persona loca. A diferencia de un diagnóstico psiquiátrico, es una identidad que yo asumí por mí mismo. Participo en varias organizaciones aquí en Chile, bromeando con los códigos de la psiquiatría, decimos que tenemos personalidades múltiples. Y lo que quiero compartir es basado en mi experiencia personal, porque a pesar de que participo en diferentes grupos, todos autoorganizados, ninguno es una fundación, una corporación, ninguno tiene finalidades terapéuticas, son grupos de activismo, de acción política en el campo de los derechos humanos, en salud mental. No me siento representante de ninguno de ellos. Solamente hablo como una persona que participa de ellos y que he tenido la experiencia de estar prisionero de la psiquiatría por varios años. Tuve la fortuna de conocer otras experiencias, tener acceso a otra información y liberarme de la psiquiatría a estas alturas ya por 10 años. Desde hace 10 años que no tomo drogas psiquiátricas, no creo en la enfermedad mental, no creo en los diagnósticos. Pienso más bien que la psiquiatría es un dogma y que no es ciencia médica. Tenemos grupos organizados de hace más de 5 años donde acompañamos el proceso de las personas que quieren disminuir o dejar las drogas psiquiátricas. Hemos escrito humildemente algunos libros, como este manual de derechos en salud mental y este libro que se llama Por el derecho a la locura en Latinoamérica. Están todos en español, pero confío en que en algún momento vamos a poder traducirlos al inglés para poder compartirlos con ustedes. Creo que la causa de los derechos humanos de las personas en el mundo de la salud mental es una causa tan buena que debería derribar las fronteras, las montañas, cruzar los océanos y borrar estas diferencias que nos pone el idioma o la geografía o la geopolítica. Eso quiero decir como presentación. Sé que hay partes que no van a alcanzar a traducirse. Lo siento por eso. Mi inglés no es tan bueno como para poder hacer la presentación completamente en inglés y expresarles mi cariño, decirles que estamos disponibles para colaborar en lo que sea. Tenemos organizado un movimiento por el orgullo loco en Chile y en Latinoamérica. Y tenemos material para compartir, tenemos experiencia en primera persona. Creemos que los cambios profundos van a venir desde nosotros y es por eso que el protagonismo en Chile lo tienen primero las personas que hemos tenido la experiencia directa y los profesionales, los investigadores, sociólogos, antropólogos, terapeutas. Los consideramos aliados, pero la revolución la hacen los locos y las locas. Entonces, desde ahí queremos compartir compartir experiencia. Estamos disponibles para participar. Si podemos lograr salvar esta barrera del idioma y ponernos a disposición. Eso es principalmente lo que quería compartir en este tiempo que teníamos pensado. Creo que la mejor manera sería a través de una grabación que podemos hacer aparte con Enrique y que tengamos el tiempo de subtitularla. Alcancé a entender algunas de las cosas que están conversando. Me parece que todo lo que tenga que ver con el ejercicio de derechos en las voluntades anticipadas, el consentimiento informado, pueden ayudar a mover dentro del sistema, pero nosotros tenemos la confianza y la seguridad de que hay que construir en paralelo. Fuera del sistema de salud mental, en los márgenes del sistema de salud mental, en las grietas del sistema de salud mental, hay que construir esas grietas y ampliarlas para crear un modelo distinto. Si hay algo que pueda entenderse como salud mental, debería salir del sistema de salud y debería estar más cerca de el modelo de desarrollo social, más cerca del modelo de trabajo, porque al mantenerlo en el sistema de salud, son los psiquiatras los que van a seguir gobernando ahí como reyes del Olimpo y eso no va a traer ningún cambio. Tenemos mucha experiencia para trabajar dentro del sistema y recuperar y redistribuir socialmente el poder y los recursos. Somos grupos autogestionados que nos movemos a través de la voluntad, a través del cariño, a través de la rabia, del dolor. Nos movilizan el amor y la profunda convicción de que podemos hacer el cambio uno a uno, apoyándonos, sobre todo las personas que tenemos una experiencia similar. Esa es la invitación que yo quisiera hacerles desde la dificultad del idioma y quedar a disposición también para recibir alguna pregunta, algún comentario de parte de ustedes para ver la posibilidad de alguna interacción.
Fantástico. Ya, Rodrigo, esto queda grabado. Todo ha sido grabado hasta el momento. I am gonna post this and everything with the transcription, con la transcripción. To everybody that is here, he is asking now for suggestions on what to cover, how to interact, how to collaborate, cómo colaborar, ¿verdad? Que estás pidiendo sugerencias, cómo crear vínculo con vuestro movimiento. It's just that how to create bridges between our movements here in Europe with them and building the momentum we were talking at the beginning of the event when Peter Groot was introducing was presenting the prescription, the tapping strips, how to achieve the gradual incremental changes, the big ones if the Granja Loca wants to achieve anything else. What would you ask him for the next recording? Estoy hablando de lo que ha ocurrido antes en el evento y qué es lo que... Pregunto, ¿qué es lo que ellos aportarían ahora?
I'm sorry, Enrique. I must go. I have an appointment. Thank you very much for inviting me, but I must leave.
Yes, thank you. Thank
Good
you,
luck,
Craig.
everybody.
Yeah. Thank you.
Likewise.
Thank you.
We are not immune to what they will do to us.
Stay in touch.
Yeah.
Good
Good luck.
luck.
Yeah.
Peter, thank you so much. It has been great. And to hear that now both of you are not in danger, that is a big deal. To hear that Craig is taking full responsibility, but also he feels that he is not going to be diagnosed. Full stop. That is something. Having that certainty it is a safety that not all of us have had. Rodrigo, si nos quieres contar lo que sea tu experiencia, tenemos aún tiempo para tratar de compartir.
Bueno, quisiera destacar el tremendo poder que han tenido en mi vida, en mi experiencia, para salir de la psiquiatría, para salir de los diagnósticos, lo que es el apoyo mutuo, el apoyo entre pares, los peer support groups. Eso es lo que más me gustaría destacar y porque creo que lo que uno no puede solo, lo puede de todas maneras en grupo. La historia de la humanidad, sobre todo la historia ancestral y en nuestra Latinoamérica, ha demostrado que la comunidad es más importante que la individualidad, que la cooperación es más importante que la competencia. Y los grupos de apoyo mutuo, los grupos de pares, han sido un pilar fundamental en recuperar la vida, recuperar los sueños, recuperar nuestra historia y empezar a escribir desde ahí una historia o un capítulo distinto en la vida de cada uno. Y todavía más, en algún momento, a pesar de estar organizados, de realizar manifestaciones, marchas, no sé cómo se puede traducir eso, scratches le llaman los argentinos, contra las principales cárceles psiquiátricas, que aquí le llaman hospitales psiquiátricos, nosotros le llamamos cárceles psiquiátricas. Tenemos campañas permanentes contra el electroshock, tenemos una campaña por una niñez libre de drogas psiquiátricas, todo lo que ocurre con las personas que se están formando. Nos dábamos cuenta de que, de todas maneras, cuando una persona entraba en una situación crítica, los recursos que siempre estaban disponibles eran los mismos: ir al psicólogo o ir al psiquiatra y terminar internado en una cárcel psiquiátrica. Entonces, desde hace 7 años, con mi compañera Toñi, mi querida compañera Toñi, desarrollamos un proyecto en el campo que se llama La Granja Loca y que creo que tiene elementos tan sencillos que es replicable en cualquier lugar del mundo. El principio fundamental es que, siendo nosotros seres mamíferos antes que humanos, tenemos una memoria atávica con la naturaleza y estar cerca de la naturaleza, en la naturaleza, nos va a producir siempre armonía y bienestar. Y el resto de este espacio de acompañamiento, este espacio de respiro, es que la persona que está pasando un momento difícil pueda estar sin apuros, sin cuestionamientos, sin juicios, que pueda hacer una rutina que le sea cómoda, que pueda hablar sin temores de las experiencias que está transitando, poder llorar libremente, poder dormir todo lo que necesite, abrazarnos si lo siente necesario, llorar juntos, comer sano, que también hace falta. Y aunque es un espacio que no está concebido como un dispositivo terapéutico, tiene efectos terapéuticos en el sentido de que las personas se sienten mejor. No tenemos la urgencia de sanar a alguien, no participan profesionales, personas que han estudiado algo relacionado con la salud, aunque pueden colaborar, Es un espacio que está pensado desde la experiencia directa por Toñi y por mí, y también incluso en el último tiempo, a propósito de una experiencia personal de duelo, mi hija menor falleció hace 3 años. Pensamos también que es un espacio muy necesario para que las personas que están transitando la terrible experiencia del duelo puedan estar en un espacio tranquilo, cómodos y tener el tiempo. La urgencia yo creo que es algo que le resta al proceso natural de restauración. Entonces, tener el tiempo de que las heridas se vayan calmando, que se vayan sanando y poder recuperar fuerza, poder recuperar energía. Eso es principalmente lo que yo quería compartirles hoy día, esta experiencia que llevamos realizando en el campo ya por 7 años. Nos retiramos de la ciudad, no vivimos en la capital, vivimos en el campo, en la naturaleza, con la naturaleza, por la naturaleza. Y si en algún momento también, con toda confianza, andan por este lado del sur, siempre van a ser bienvenidos para pasar unos días con nosotros aquí en la Granja Loca. Eso.
Maravilloso. Rodrigo, gracias. They are inviting you to visit the Granja Loca. It's a place in the countryside. I did my best to share this in the chat. It is a wonderful project, and I would love to know how's it working, etc. All that the scientists will just ask. How does it pan out after? ¿Cómo funciona? ¿Y qué tal la gente cuando va y cómo sale? Si quieres, if you want.
Sí, 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 sí. Mira, yo sé que es muy interesante para la investigación, pero yo siempre digo que lo más interesante es vivir la experiencia. No hay una manera mejor de investigar que vivir la experiencia, por eso es la invitación. Pero para compartirle es algo muy sencillo. Es
Peter.
algo... Oh, Peter.
Sorry, I have to leave. My wife calls for dinner. This is a must.
Ajá.
Sorry.
No.
Buenas
Enjoy.
noches.
Gracias.
Buenas noches.
Buenas noches.
Buenas noches.
Thank you.
Gracias.
Tiene 2 claves, yo voy a decir. La primera clave es que cuando un niño invita a jugar a otro niño, nunca se preguntan los objetivos principales, los objetivos secundarios, ni la metodología, ni los indicadores. Los niños van y juegan y viven la experiencia. Esto es más o menos así. Y lo segundo es que, como no está concebido como un espacio terapéutico, es una experiencia tan natural como si tú tuvieras un amigo que está pasando una situación, un momento difícil, y quisieras ponerte a disposición de él para apoyarlo. Entonces, esa es la invitación. Han participado, hemos estado en 3 lugares distintos, todos en el campo, fuera de la ciudad, y han participado en este momento, hasta el día de hoy, han conocido el lugar, unas 50 personas, y lo han usado para los fines que fue creado, unas 15 personas. Personas que tenían ideación suicida, personas que iban a ser internadas, personas que estaban tomando drogas psiquiátricas y querían disminuir esas dosis, personas que estaban amenazadas por ser internadas y han estado desde un día hasta una semana. Pronto vamos a recibir a una persona que va a estar cerca de un mes con nosotros, porque básicamente está la persona el tiempo que quiera. Condiciones esenciales son que la persona venga voluntariamente y se puede ir cuando ella quiera. No hay aquí un protocolo de entrada, un protocolo de salida. Nadie entra obligatorio y nadie se mantiene obligatorio. Y yo diría que la otra condición esencial, como dije antes, es que no está dirigido ni controlado por profesionales, está coordinado por nosotros. Tampoco le cobramos a las personas para que vengan, porque no queremos que estar, al mismo tiempo de estar pasando una situación difícil, sea un problema el aspecto económico. Así que lo hemos podido sostener por nuestros propios recursos. Si la persona tiene dinero para poder solventar los gastos que implica estar aquí, es bienvenido, pero no es una condición excluyente que tenga recursos para estar. Eso también facilita mucho las cosas. Sabemos que es difícil sostenerlo en el tiempo y estamos buscando algunas estrategias, pero facilita mucho que las personas puedan venir y llegan por referencias directas porque no tenemos publicación, no hacemos publicidad, porque funcionamos de una manera anarquista, vamos a decir, fuera del sistema, de una manera hippie, o creemos en la abundancia del universo, y siempre hay personas que nos colaboran, que nos regalan recursos, materiales o dinero, y así hemos podido sostenerlo en el tiempo. Eso en términos generales es como la simpleza, también para transmitir que esto no necesita necesariamente un gran financiamiento o una gran estructura para hacerlo funcionar, sino que principalmente la voluntad, las ganas, el cariño de hacer un cambio real y en el fondo es recuperar lo ancestral, lo tribal, lo comunitario, lo gregario. Somos seres gregarios, somos seres sociales. Ponerse a disposición de otras personas también es un elemento importante para la propia curación, si sirve también esa parte de compartir, sacar la atención de uno mismo, que uno se convierte como en un hipervigilante, y ponerse a disposición de otras personas, también es parte del ejercicio que hacemos aquí. Eso.
Alejandra, no se te escucha. Pon el micro. And my apologies, Rainer. I'm gonna do my best to synthesize at the end everything.
Ahora sí. Rodrigo, quería
Sí, se
felicitarte.
escucha.
Soy Alejandra, soy médica de familia, soy argentina, pero ahora estoy en España y la verdad que, bueno, quería felicitarte a ti, pero en realidad toda la comunidad está de Granja Loca. Creo que aquí en España también está un grupo de apoyo, son asociaciones que es Orgullo Loco también, ¿no? En esa misma línea, ¿no? Y bueno, activismo que se llama, ¿no? Y creo que formáis parte de un soporte fundamental que creo que a mi juicio como médica me tengo que ubicar y lo digo desde el sistema de salud. El sistema de salud no podemos dar ese soporte que Granja Loca da a las personas. En mi caso personal, soy médica de familia y tengo solo 5 minutos para atender a un paciente, a una persona. 5 minutos para escucharla, me parece una verdadera desgracia para el paciente y frustración para el médico de familia, tener que garantizar una calidad a través del reloj, ¿no? De las agujas del reloj. Y entonces a partir de ahí, los médicos de familia no podemos dar esa escucha activa, ese soporte quizás emocional o simplemente escuchar al paciente, ¿no? Que es lo que hemos perdido, al menos en mi perspectiva, ¿no? Lo hablo así. Y creo que, bueno, que vuestro grupo, vuestro proyecto está brindando no solamente un espacio para dormir, para poder escucharse, sino que es un espacio de sanación, como tú bien lo has dicho. Y quería preguntarte si a mí la verdad una de las preocupaciones que tengo en este momento son los niños y es con el diagnóstico que realmente me llegan a la consulta de trastorno por déficit de atención. Entonces creo que los niños tienen que moverse, los niños tienen que jugar, los niños tienen que expresarse, los niños, hemos sido todos niños y todos nos hemos movido, pero ahora parecería ser que si te mueves mucho ya tienes la etiqueta, el diagnóstico, el desorden de trastorno por déficit de atención. No sé qué experiencia tienen ustedes con niños.
Por esa misma razón, gracias por tu comentario. Y por esa misma razón es que levantamos la campaña por una niñez libre de drogas psiquiátricas y es una de las ramas que nacieron de este movimiento. Ahí hay unos compañeros y compañeras que se hicieron cargo de eso, han hecho encuentros con niños, desarrollaron un manual para los padres y apoderados y para los educadores. Entonces, a través de Enric podría yo enviarte ese material o ponerte en contacto con esos compañeros para que pudieran compartir la experiencia y el material, porque precisamente está ese análisis crítico de que se quiere normalizar a un niño, se quiere tranquilizar a un niño en vez de pensar en cambiar el sistema. Y también comentarte que precisamente porque sabemos que el sistema tiene otros intereses, tiene intereses más bien economicistas, es que se diseñan las prestaciones así, po, con un tiempo increíble de acotado, como casilleros para llenar rápidamente, derivar lo más rápido posible a una etiqueta diagnóstica y a un tratamiento farmacológico, a los dispositivos, una maquinaria que se convierte al final en que los usuarios son usados para sostenerlo. Entonces, por eso es que no tenemos mucha o muy poca o nada de confianza en que desde el sistema vaya a venir un cambio. Por eso es que desarrollamos esta alternativa al margen. Y también agradecerte ese reconocimiento para el colectivo, porque aunque a mí me ha tocado en esta oportunidad compartirlo y me ha tocado cierto protagonismo a lo largo del tiempo, es un trabajo que es de muchos compañeros y compañeras a lo largo del tiempo, sostenido con el cariño y con la fuerza de querer un cambio, de querer un cambio mejor. Así que si te parece bien, a través de Enrique, yo te pongo en contacto con los compañeros para que puedan compartir eso, ese material y esos contactos, si te pueden servir para tu trabajo.
Sí,
Con
sí,
mucho
sí, sí.
gusto.
Muchísimas gracias, Rodrigo. Sí, me interesa y claro que lo voy a compartir y si puedo lo voy a intentar divulgar en mi entorno. Que, que bueno, que la verdad que si tenemos, si los niños españoles o los niños en general pueden estar libres de drogas, ¿cuánto más vamos a hacer por esos adultos libres de drogas?
Así
Drogas
es.
psiquiátricas, drogas que somos en
Sí.
realidad los prescriptores responsables de ese inicio, ¿no?
Ujú,
Porque luego me pregunto cómo, entre comillas, destetamos, desmedicalizamos ese proceso, cuando lo estamos
ujú.
comenzando con niños de 4 o 5 años.
Así es. Sí. Así como decía Craig, creo haber entendido que ya es un hecho, cualquier análisis se da cuenta de que la psiquiatría ha ampliado la malla de los diagnósticos para capturar clientes lo antes posible. Claro,
Ujú.
se construyen pacientes psiquiátricos a temprana edad, con gotitas de
Efectivamente.
risperidona, con estos diagnósticos. Entonces, la mayoría de las compañeras que están en los grupos de desmedicalización que creamos y que sostenemos hace 4 años, son mujeres, primero, y han partido en una etapa muy temprana con medicación por déficit de atención y entonces luego trastorno de ansiedad generalizado y entonces después algo un poco más fuerte y resulta que no era eso, era bipolaridad o borderline, en fin. Así va evolucionando la industria farmamentística, le decimos nosotros, y, y el imperialismo del diagnóstico. Así que sí, podemos compartir. Eso también es un poco la idea de estar en estos espacios, poder tejer redes y poder trabajar juntos.
Muy bien, Rodrigo, sí. Te felicito, os felicito a todo el grupo. Y a Enrique,
Gracias.
por supuesto, por visibilizar
Sí.
esta problemática. Enrique, muy bien, muy grande. Qué grande eres.
Estás muteado, parece.
Ya. No os pude traducir lo que estaba diciendo Reiner antes de irse, es que él está sin esperanza. Parece que han malinterpretado lo que estábamos diciendo, lo que he tratado de traducir con el vínculo con la naturaleza, que todos compartimos como lo que somos. Y no son suplementos naturales, no se trata de eso. Yo también he visto gente con la mentalidad de las medicaciones y están con los gramitos ¿qué? Semillas, por favor, estás hablando de algo distinto. No es esta la mentalidad con la que te presentas tú al lugar donde yo tampoco sé cómo vais a jugar con cualquier adulto que te entre, porque esto es ponerse una persona en casa. Lo que estás diciendo un poco es cómo se traduce eso a un sistema de salud que está desbordadísimo. Hay un planeta de distancia entre una realidad y la otra, y no sé lo que estáis haciendo. Me parece fantástico y estoy empezando a ver que es con mujeres que han sufrido muchísimo, son personas que no van a causar los problemas, al contrario.
Es que no le tenemos miedo al desborde, no le tenemos miedo. Hemos pasado por esa experiencia. Entonces uno se relaciona con las personas desde el cariño, desde el amor, desde la confianza, desde la comprensión. No tenemos urgencia. Entonces también eso se transmite a las personas que están en un momento sufriendo. Y cuando perciben que está esa energía, todo va fluyendo. Ha habido casos más desafiantes que otros, pero como tampoco tenemos la pretensión de dar de alta a alguien o sanarlo, no es un tema, lo vemos a largo plazo. Quizá a nosotros nos toque en la granja loca intervenir o acompañar una parte de la historia de la persona, pero el proceso completo la persona lo va a terminar por sus propias vías, por sus propios medios, con sus propias estrategias. Es algo mucho más amplio. No es una visión, no está pensado como una intervención, está pensado como un acompañamiento y con la libertad de que la persona puede tomar sus propias decisiones. Si una persona viene a la granja loca y tiene un cuadro farmacológico, nosotros no lo vamos a intervenir. La persona lo puede seguir usando todo el tiempo que quiera. Le podemos informar, le podemos entregar información, tenemos el deber de hacerlo, compartir la información que normalmente no tienen, pero eso, la persona toma sus propias decisiones y nosotros las respetamos, sean cuales sean, incluso las que pueden parecer más radicales y con las que no estemos de acuerdo, porque no tenemos por qué estar de acuerdo tampoco. Eso.
Una peregrinación a Chile, eso sí que es difícil. Lo que habéis compartido, y realmente puede ser más simple, ¿sabes? ¿Para qué irse a una granja si puedes irte, vete tú, ¿sabes? Tienes los lugares.
Quería compartir algo con vosotros cuando estaba yo realizando mi tesis y me interesaba saber cómo la población musulmana, bueno, en especial después de la islamización aquí en España, cómo, qué soporte, qué soporte, así como que fuera la granja loca, hicieron los musulmanes aquí en España. Y no sé si ustedes sintieron o alguna vez escucharon o leyeron de bimaristanes. Los bimaristanes eran lo que se llaman, es una palabra árabe, bimaristán significa hospital, pero en realidad es como dar hospitalidad a las personas, hospital no de hospital psiquiátrico, sino dar hospitalidad a las personas con alguna necesidad, ya sea porque se encuentran solas, porque era un abordaje holístico de la salud mental, en los cuales se tenían un área, ellos mismos cultivaban la tierra. ¿Y sabes dónde estaba, Enrique? Tú que sabes, aquí en Granada, debajo de la Alhambra estaban los bimaristanes. Un bimaristán, que lo están reconstruyendo. Te voy a mandar material para que lo leas. Y entonces los bimaristanes tenían un área donde había no internamiento, había lugar para dormir. Las mujeres por un lado, los hombres por otro. Había lugares, bueno, tenía que tener sí o sí un lugar donde las fuentes estuvieran brindando siempre ese sonido mágico que da el agua, ¿no? Tenía que haber un lugar donde hubiese también flores, un lugar donde hubiese plantas aromáticas, naranjos, donde todo eso también ayuda para que el individuo entre en un estado, en un equilibrio, el equilibrio entre la salud y la enfermedad. Ese desequilibrio es lo que ellos procuraban equilibrar a través del sonido del agua, de las plantas, y realizaban ahí mismo las medicinas, pero a base de plantas. Y un detalle más, tenían músicos que tocaban el laúd y músicos que simplemente tocaban melodías suaves para cuando había que generar un estado de tranquilidad, pero para aquellos individuos que estaban en estados de depresión, de mutismo y demás, bueno, quizás interpretaban músicas mucho más movidas y daban a este entorno un tratamiento holístico, ¿no? Y se llamaban bimaristanes. Estamos hablando del siglo VII en España. Es lo que ahora llamaríamos granja loca, los bimaristanes aquí en España, ¿no? Y vienen, bueno, de toda la línea de los Omeyas, y bueno, es algo muy, muy bonito, porque cuando tú hablabas de eso, yo me imaginaba los médicos musulmanes como que, bueno, que a ellos les debemos mucho también aquí en España, y no están tan reconocidos porque, bueno, ellos hicieron también nos dejaron este enfoque holístico de la salud mental. Bimaristanes.
Me
Bimaristanes.
interesa esa información también, por si la puedes compartir.
La compartiré, se la pasaré a Enrique y te pasaré, bueno, ahí en mi tesis está el proyecto que tiene Granada de darle reconstrucción a ese bimaristán que está a los pies de la Alhambra.
Genial.
Yo
Gracias.
Alejandra, soy tan tonto, me lo imaginaba en el sótano de la Alhambra, debajo, pero debajo, porque no sería tampoco tan extraño. Por desgracia o por no, para decirlo, también tenemos la costumbre de los hospitalarios y los templarios en el piso de arriba, entrando y saliendo de los lugares, y los conflictos que ya sabemos dónde estaba. Eso eran las cruzadas y todo. Es terrible que, primero, que le hemos olvidado todo lo que se puede hacer y lo que ha ocurrido, y después que lo que le debemos, por supuesto, la tradición estupenda de haber traducido a los griegos como si fuéramos tan tontos. ¿Estamos simplemente agradecidos por eso? No, es porque realmente compartimos la esperanza de que se pueda hacer mejor. Y la casa de la Bagdad, ¿cuándo cayó? Yo no lo sé si fue el siglo VIII o el VII, no lo sé, pero la casa de la cultura hay. Las casas de la cultura, ¿dónde está el conocimiento, la capacidad humana de... Es terrible, pero es que tenían la esperanza, y eso es lo que yo he escuchado, de ir a vivir para siempre, porque tenían simplemente el momentum ahí de científicos, gente de ciencia, gente de saber, juntándose en Bagdad. Y habían cogido ya, lo digo porque han caído muchos intentos sin enloquecerse, pero tenemos la capacidad humana de hacer mucho más de lo que estamos haciendo. Después nos vienen las invasiones, nos vienen las guerras, nos viene todo encima. Somos tan tontos que hemos olvidado que la cultura musulmana era y sigue siendo algo que no es una... ¿Sabes? Lo miramos aún muchas veces. Esos nunca han sido científicos, son... Pero por favor.
Sí, sí, sí.
Bueno, con el fuego de la esperanza, me quiero despedir, agradecerles y quedar a disposición para lo que sirva, para lo que venga. Aquí estamos en este sur del sur.
Por supuesto. Y se dice así, parece locura, pero simplemente vivir una vida y que no te la quiten, porque es
Ajá.
lo que ocurrió a todos.
Bueno, yo también
Muy
voy a
bien.
despedirme, Enrique. Muchas gracias por el espacio. Perdón por mi precario inglés, pero bueno, quise también sensibilizar a los compañeros médicos de la problemática que tiene la población musulmana. No es una problemática de la población musulmana, es una creencia de la población musulmana que se transforma en una problemática cuando los profesionales no comprendemos sus creencias.
Lo que ocurre acá con los mapuches.
Efectivamente.
Sí.
Ujú.
Bueno,
Bueno,
gracias.
gracias, Enrique. Adiós, hasta luego.
Abrazos.
Hasta
Gracias.
luego.
Vemos.
Gracias, adiós.
Adiós.